just to give you, a brief overview. As criminologists, we think about some of the broader pictures of how things can impact society. And obviously, we are going through an unprecedented time in our history with COVID. I mean, never in our lifetime did, I'm sure, any of us ever imagine we would be living through a pandemic. And sadly, though, we are. And hopefully we're on the back end of that into an endemic. But bottom line is that what we want to look at today, and we are so pleased that all of you could join us today, because this is quite an interesting topic, and we're going to have a lot of different perspectives here. We're going to be looking at policing. We're going to be looking at it from domestic violence and victimology to looking at it from a clinical perspective. How has it changed in terms of hospital admissions and what they're seeing coming into the hospitals in terms of victims? So basically, what we're trying to do here today is look at how COVID impacted this larger area. How was policing? How were the medical field? How was domestic violence and other types of victimology impacted by this pandemic? And it's just an opportunity that we need to think about beyond just the health implications of COVID. What are the other consequences of COVID that perhaps we haven't yet thought about or addressed? And today, what we are really excited to do is to be able to bring some of that to you through this very unique group of people who have a stellar reputations. And on that note, actually, I think what we should do is let Carla introduce our panelists, and we can get in and hear their talks, and then we're going to open it up to Q&A, of which I'm sure there's going to be a lot of that. So I don't want to actually waste too much of our time on me, because you would be much rather talking to our panelists. So Carla?
So first up, we're going to talk to Dr. Tanya Egodage. And Dr. Egodage is a practicing trauma surgeon at Cooper University Hospital who is triple board certified in general surgery, surgical critical care, and neurocritical care. She has an interest in improving care for injured patients through process improvement, and research endeavors. Dr. Egodage is the recipient of a Camden Health Research Initiative grant to evaluate frailty amongst trauma patients. She has also received state and federal funding to improve outcomes for victims of violence at Cooper Hospital. Dr. Egodage is locally involved with the Cooper Medical School of Rowan University and serves as Associate Program Director for the Surgical Critical Care Fellowship at Cooper. She's active in several national trauma organizations and collaborates with trauma centers across the country in her research. And she's also actually lectured internationally on best practices in early trauma resuscitation and care of the injured patient. So clearly she's a very qualified and very busy woman, and so we're really proud to have her here today. And today, Dr. Egodage will discuss trends in trauma care during COVID-19 pandemic. So with that, I'll let you take it over.
Yeah, thank you for the kind introduction. Let me share my screen here. Thank you for the kind introduction. I'm Tanya Egodage. I'm one of the trauma surgeons here at Cooper Hospital. And, this is a fascinating panel. I'm happy to be here and speak with such esteemed colleagues from across the nation. So today we'll talk a little bit about what we saw from a trauma surgeon perspective and a clinical perspective during this pandemic. And, COVID-19 really was sort of, although it was a pandemic, it was also very local, regionally strained, and it strained a lot of our resources on both frontline workers, EMS, firefighters, police department, but also on our physical hospital resources as well. And you can see that it perhaps wasn't isolated to a single part of the country, but there was these sort of surges that we noticed throughout the country over time. And we had anticipated, there were various models that anticipated changes in medical practice, which then became realities. And there was a significant strain on the healthcare system, including shortages of beds, shortages of ventilators, personal protective equipment, and also personnel. Physicians and nursing staff were in short order, and we were having to deal with all of these shortages. Initially, there were several guidelines that were proposed that were then amended as the pandemic went on. Here you can see a couple of our national organizations. The American College of Surgeons published some, along with their subgroup on the Committee on Trauma, as well as some of the international European guidelines. Basically discussed how we would redeploy physicians, specifically surgeons and trauma surgeons who are board certified in critical care management, so they can handle, taking care of COVID patients, managing other medically complex patients. We sort of discussed how to triage patients that would require surgeries, because again, we are surgeons and performing surgeries on a broad group of people. But we had to sort of go into this mass casualty sort of scenario in which we were triaging people who were most sort of important, which also became an ethical conversation at that point. Is somebody's stage 4 cancer, is that considered important, or is that not? Is that something that can wait? And how do we maintain emergency systems throughout this time? So all of these were very real conversations that were had. And I think, from a clinical perspective, everybody tried to pitch in and help where able. And there were places in the country where trauma surgeons being certified in critical care were redistributed to other areas of the hospital. So one of the questions that we had in New Jersey and at Cooper Hospital was, is that appropriate? What were the trauma trends that we saw, both locally and nationally? And is it appropriate to sort of diminish the number of resources that we have to care for trauma patients? And when I say trauma patients, I mean anybody who is acutely injured. So that can include a firearm injury, that can include a stab wound victim, that can include somebody who was involved in a motor vehicle collision, somebody who fell, anybody who is acutely injured. So is it appropriate for us to redistribute these resources? This is from the Kaiser Family Foundation, just a schematic of when the stay-at-home orders were implemented across a number of states. And you can see there was a variation depending on sort of local regional spread of COVID. And throughout all these, we had a number of papers that came out. Again, over the past 2 years, different centers have published data on this, and we've also collaborated on data. And I'll go through a few of these. These are the data that we actually had at Cooper Hospital. So our question initially was, did an executive order affect the rates of trauma? And here you can see our 2019 admissions per day and our 2020 admissions per day, which is highlighted in orange. And the executive order in 2020 is marked by these two blue lines. And as you can see, initially there was a decrease in the number of trauma patients admitted per day. But then after about 3 or 4 weeks, there was actually a return to baseline. So we found that the number of trauma patients we received was not really correlated with any type of executive order. And in fact, we wondered, what were the additional resources that were used? Were we using less blood products? Were we or fewer blood products? Were we using fewer ICU beds? And we found that specifically during this executive order in New Jersey, there was no change in the use of these resources. So we had perhaps actually had an increase in the percentage of penetrating trauma, which meant an increase in the percentage of firearm injuries and in the increase in the percentage of stab wounds that we saw. There were no change in the percentage of batteries, in transport-related accidents, and in falls. And interestingly, no change in ICU length of stays, the number of procedures that we had to perform, meaning operations for these acutely injured patients, no change in the blood transfusions, and no change in the overall mortality of patients. So this is really interesting to us. And I think will help us going forth understand that we do need to allocate resources for patients who get injured, because actually, aside from a couple of weeks in which we saw a downtrend, it really returned to baseline. And this was demonstrated across the nation. This is from Northern California. Again, increase in the rate of penetrating injury, and they found battery during the pandemic, more operative interventions, more transfusions, but no change in mortality. This is another one from LA County, also another urban setting, which demonstrated an increased rate of penetrating trauma. And again, you can see here, I think the orange, which was March 19th, is the extent of their executive order in California, and you can see an initial decrease, but then a return to baseline by June. This is another one from Chicago, which demonstrated similar results, an increase in penetrating trauma percentages. So it's very interesting. These results were very interesting. And overall, throughout the course of the pandemic, over the year and now the 2 years that we have been in this, trauma numbers themselves have actually been relatively unchanged. At Cooper Hospital, we actually saw an increase in the number of traumas that we received over 2021 and now 2022. But the distribution of those changed a bit. So although there was a decrease in the numbers initially, there was then a rebound and an actual increase in the rate of penetrating trauma, so which we found to be very interesting. And this furthers the question, what do we expect in the post-pandemic era now with the relaxing of sort of mandates and decreases in trauma, in COVID numbers? I think what we've seen also is a significant change in the economics of people in the nation. And I think we're going to see the results of that as hospital admissions and as traumas, because, trauma, patients getting injured and things like that can be affected, obviously, by socioeconomic changes. So we actually do anticipate an increased level of trauma admissions going forth with the relaxation of these mandates and given the economic challenges. So interestingly, I just want to add one slide. We have received some funding, Cooper Hospital, from both the New Jersey Office of the Attorney General and now from the Department of Justice, which I'm collaborating with, I think, Dr. Master-Cinque, who's on this call, to assist people, who are going through these economic challenges and hopefully try to reduce the recidivism amongst victims of violence. So hopefully we'll try to curb some of these anticipated increase in trauma numbers, but that's sort of where we are. I will answer questions during the panel setting, and thank you for having me.
Thank you so much, Dr. Egodage. We really appreciate it. That was really interesting. I actually had never heard of the term penetrating trauma, so I learned a lot there. All right, so next we are going to have questions at the very end, but for now we're going to have Dr. Tara Richards, and she is an associate professor in the School of Criminology and Criminal Justice at the University of Nebraska, Omaha. She's also a faculty lead for UNO's Victimology and Victim Studies Research Lab. And her research primarily focuses on prevention, intervention, and system responses to sexual assault, domestic and intimate partner violence, and child abuse and neglect. She also serves on the Douglas County Domestic Violence Coordinated Response Team and Sexual Assault Response Team, and coordinates Nebraska's Victims Assistance Academy for Advocates and Allied Professionals in Nebraska. So thank you again for joining us. And today, Dr. Richards will be discussing what we know about how the COVID-19 pandemic impacted domestic and intimate partner violence in the United States. And this was something that I know Kim and I really wanted to know more about. So we're definitely excited for this. And she's also going to speak to the challenges in measuring changes in quote, hidden crimes like domestic and intimate partner violence, and the ways in which innovative research practitioner partnerships can help to overcome those challenges. All right, take it away.
Thank you so much. So, hey guys, I'm Tara. It's really nice to be here. I really appreciate John's invitation to come and talk to you guys. So this presentation is a sort of a little bit of a spin-off of a presentation that my team, so that includes Dr. Justin Nix at UNO, and then also Scott Morkos and Ian Adams at the University of Utah. We've given this talk in a couple different forums at the UN UN Commission on the Status of Women. We gave this talk in 2021, and then also at the American Society of Criminology conference last year as well. So I titled this, What We Know About How COVID-19 Maybe Probably Impacted Domestic and Intimate Partner Violence. Because I think it's important, as the previous presenter talked about, that we're still learning, we're still uncovering data. And so, trends are continuing to reveal themselves over time as new data become available. So without further ado, I just want to first mention why COVID-19 might have impacted domestic and intimate partner violence perpetration and victimization, right? Because it's not we don't believe that it was the virus itself that impacted victimization and perpetration. Instead, it's some of the related changes in routine activities, right? So people started staying home, either because they had to, because of stay-at-home orders, or because they elected to, because of the pandemic, right? So people started staying home, which meant that victims and would-be victims were spending increased time with their abusers, right? We also saw separation of victims from their safe places and their support providers, right? So there was no school, no church, no work, so nowhere to go to sort of separate yourself from an abuser when a situation might escalate, right? There were increases in stressors, right? So we saw increases in financial stress, with unemployment, with changes in work, increased parenting stress as folks started staying home with their children, and remote school became a reality. For folks that were doing remote kindergarten, remote first grade, remote second grade, I bow down to you. That seems impossible, especially when you were also trying to pivot and work remotely as well. And then there was a lot of uncertainty and fear around the pandemic, right? So it was a highly stressful situation. And then we also have seen through the research that has come out over the last couple of years, there were increased rates of alcohol use, right? And particularly increased at home. So where folks, while alcohol use does not cause domestic violence, it is definitely a risk factor, right? So problematic alcohol use, less stress, can oftentimes end up in an explosive situation like domestic and intimate partner violence. Including analysis of about 36 studies found, generally speaking, there was an increase in calls for service to police for domestic violence right in that period, directly after stay-at-home orders. We also see in a few studies by econometricians that DV-related calls for service in these months directly after stay-at-home orders were actually concentrated in city blocks where there had not been recent calls for domestic violence service. So some indication that we were also seeing new calls for service from households where there hadn't been a call for service before, right? So maybe some indication of new help seeking. Now, we don't know whether or not that was because of new victimizations, or perhaps because there were more people home, right? There were kids home, there were neighbors home, to perhaps hear victimizations happening and make reports, whereas, there may not have been a report. And then we also see that these increases, these spikes in calls for police service for domestic violence really normalized pretty quickly. So after, about a 3 month period, after sort of mid-March, we see, these increases really going back to baseline. And then we also see incredible variation from city to city, right? So while we talk about sort of these general trends, when we aggregate all these together, I think it's really important to note that there wasn't one trend or one pattern. We really see a lot of variation from city to city. So to sort of highlight this, these are findings from a study that my team did looking at data across 7 cities. So Baltimore, Cincinnati, Hartford, Connecticut, Orlando, Florida, Sacramento, California, Salt Lake City, Utah, and St. Petersburg, Florida. And we looked at police calls for service for domestic violence, and then I'll show you in a minute, actually domestic violence calls to emergency hotlines in these same cities. Looking at trends over about a 2-year period, because I think it's important to note, as our previous presenter did, that An increase in those months after the stay-at-home order is really meaningless unless you look at the same time in previous years, right? Because as we know as criminologists, right, there are seasonal trends in crime. So just because you see an increase in the spring of 2020, you can't necessarily denote a change because of, COVID or any other sort of event that's happening without looking at, data from previous years, right? To see, is this really a difference, or is this what we would have expected to see anyways in March and April and May and June, given those seasonal trends? And what we found when we looked across these 7 cities were really incredible variation in police calls for service for domestic violence. So, for example, in Baltimore, Sacramento, and Salt Lake City, we saw these increases in calls for service that were sustained over time. So, just to kind of help you out, because I know the chart is small and not everyone is doing, longitudinal analysis. But what we basically did was we calculated the observed trend, right? So the number of calls for service that we were seeing, and that's demarked with that green line that goes across. And then we also estimated a counterfactual trend. So basically, given the 2 years of data that we had before COVID-19, what would we expect to see, right? But for COVID-19, or but for the data that we had after the stay-at-home orders. And I should let you guys know that we used March 9th as our date for COVID-19 because across multiple studies, there's this consensus that March 9th is really when people started staying home. So looking at sort of cell phone data across the country, open table reservations, and other web-based data points that would show where people are, we see that people really started staying home March 9th. So that's really our demarcation for where COVID began. So in Baltimore and Sacramento and Salt Lake City, we saw the same increase. In Cincinnati and in Hartford, we actually saw a decrease in calls for domestic violence, because we know that actually the majority of domestic violence victims don't call the police after abuse, or they don't always call the police after abuse, and about 41.4% of victims reported that victimization to the police in 2020. So we saw, again, incredible variation across the jurisdictions. So we saw a decrease in calls to the hotline in Sacramento. We saw initial increases in Orlando and Cincinnati, and we saw these sustained increases in Baltimore, Hartford, Salt Lake City, and St. Petersburg, Florida. So again, just to sort of show you the trends visually, we saw, this incredible variation of both the trends and then what we observed after that March 9th date in comparison to what we would have assumed we would see given the 2 years of data that we had and the number of calls for service that had been receiving over time. So when we looked at the increase of calls and we totaled them all together, what we saw is that emergency hotlines received about 1,671 more calls to their hotline than we would expect given the trends that they had, that they've shared with us for 2018 and 2019. Okay, so what about what victims are saying, right? Because when we think about understanding or measuring victimization, the best measure of that is victimization surveys, right? To actually ask folks, have you experienced this victimization, right? And so, as I indicated earlier, the NCBS just released their 2020 data, and what the NCBS tells us is actually the rate of victimization decreased in 2020, right? So, I haven't analyzed the data yet to look at the actual trends, but that would be very interesting, and I'm very excited to be able to do that, to look at sort of when to look at sort of recurrent victimization, trends in victimization over time, according to the NCBS, now that we have that 2020 data. But what I think is really important to note is that with all of our sort of hypotheses and assumptions about how COVID was going to impact victims, the best data we have on victimization actually notes a decrease in rates of domestic violence victimization, right? As well as a decrease in rates of intimate partner violence victimization. Again, the NCVS breaks those two measures out, distinguishing between domestic violence, which is violence between other types of family members and close interpersonal relationships, versus those former and current intimate partners, which would be intimate partner violence. So what does this all mean? Maybe probably, I think, right? So overall, police calls for service and hotlines, hotline calls, which is help seeking for domestic violence and intimate partner violence. We see that generally calls to police increased during that sort of the height of COVID-19, right, where we were seeing those stay-at-home orders happening, the social distancing happening. We were all, we were all quarantined to our houses, but this was really short-lived, right? In most cities, this was short-lived. So what could have possibly been going on, right? It could have been indicative of many more third-party calls, right? And there's some research in the economics literature that's actually suggesting that it is these third parties, right? We also don't know about escalations in violence, right? So perhaps there was escalating violence, and so victims were calling, or children in the home were calling, in situations where violence was, this was a violent relationship, but the victim, didn't usually call the police, right? And then also it could have been these first-time perpetrations, right? Because we do see some evidence that there were certain city blocks and neighborhoods where domestic violence calls were coming in, where there hadn't been recent DV calls for service, right, to police. We also see generally that calls to hotlines increased, and in some cities, these sustained over time. So what could this mean? Well, this is, could be indicative of the fact that victims had to stay with their abusers. They couldn't leave. They couldn't go anywhere. They didn't have that respite in church, in school, in work. Their kids were home. And we do see in the literature that surveys with victims, interviews with victims often say they leave, they call the police when they think their kids are in danger, right? Like, I can handle it. I know how to moderate, my partner. I know when he or she is going to get violent, but it's when I think, I thought that they were going to hurt my kids. That's when I call, right? That's when I hear this. But we do know from sort of a theoretical standpoint and an abundance of research from Jackie Campbell at Johns Hopkins, specifically, like, when a victim leaves, that's when they're at the greatest risk for. So I'll leave you with a few lasting thoughts about implications moving forward, and really what some of these studies and really sort of these exercises in trying to measure domestic and intimate partner violence in real life. We are also, in terms of the criminal justice system, victim service providers, health providers, most jurisdictions like to think that they have a coordinated community response to domestic violence. Douglas County, Nebraska, Omaha, we like to think we do, but we're not very good at sharing data. Right. So, the victim service providers, they're over here with their hotline data. Law enforcement, they're over here with their calls for service data. The emergency department is over here. Then we would have an understanding of localized trends, because crime is local, right? So looking across these jurisdictions, if we aggregate it all together and we see this trend, domestic violence calls for service increased. Well, did they, right? Maybe not in your jurisdiction, maybe not in your community, right? So I think there's some real, considerations to be made about, can we better share data across these different systems, right? To have a better understanding of localized trends so we can deploy resources in real time, right? And that's where I think these researcher practitioner partnerships can come into play, that we could better support our coordinated community response teams for domestic violence.
Dr. Richards, that was a really fascinating presentation, and I think it really goes to show just how much sometimes you think it's going to go one way and it doesn't, and then you really have to craft a narrative and try to explain it, because I would have thought all those numbers were going up. But thank you very much. All right, so our last speaker will be Dr. Stephen Bishop. And I don't know if you like to go by Dr. Bishop or Lieutenant Bishop.
Either is fine.
Okay. Dr. Bishop is a lieutenant and 31-year veteran of the Dallas Police Department. He commands the Data Analysis Management Unit, which includes functions such as the state, federal crime reporting and crime analysis. Steve received his Ph.D. in criminology from the University of Texas at Dallas, and his research interests include evidence-based policing, use of force, police mental health and well-being, which I think is going to be a big highlight of your presentation today, and criminological theory. So he's had some recent publications in very prestigious journals, including Justice Quarterly, Crime and Delinquency, Policing and International Journal, Justice Research and Practice, Injury Prevention, American Journal of Public Health, Deviant Behavior, and Police Quarterly. So today, Dr. Bishop will briefly discuss the findings of two of his more recent studies, each of them utilizing Dallas Police Department crime data. He will also discuss the effect of the pandemic on officers, which I think will be a really interesting perspective since we've been learning a lot about the victims, but now we get to see the police officers who it no doubt affected. And also what he himself has observed as a supervisor and co-worker. And so that'll include the dynamic nature of departmental policies about citizen contacts and arrests during the pandemic. So with that, I give it to you.
All right. Well, thank you very much. I appreciate that, Carla. The presentation I have today is no PowerPoint, so you just get to watch me talk. But I really wanted to keep it at a more of a personal level rather than a research level, so you get kind of an understanding. Particularly, Dr. Richards, I provide you some context of why some of these numbers might be driven the way they are, just from a local level. But really, so. The two studies that I have co-authored on the effects of COVID, in particularly, we looked at the first paper we looked at was how the stay-at-home orders, not so much COVID, but the orders from the state of Texas to stay at home where businesses started closing down. And so to go over that real briefly, because again, from what I understood from Dr. Richards, a lot of our research is really underscores what she is finding across cities. I was just particularly interested to see such variation across cities. I'd kind of be interested in why you think that might be, Dr. Richards, but we'll get into that later. So I just want to start out. The first paper we did was a very short analysis. And just a few days, not a few days, but just over the first couple of months when the stay-at-home orders began to take effect. And our time series started on the 24th, which was the first initial stay-at-home orders. And then, of course, across time, they started breaking those out, which our second paper got into, where they started releasing some of that. But what we found really initially in our first study, I guess the gist of it was that when they initially had the stay-at-home orders, we saw a spike in domestic violence, because that first paper was just centered around domestic violence. We saw that a spike, but then it began to lower a little bit. What we couldn't tell was if possibly that spike had already started. And as it was already pointed out, the actual date of COVID was before the stay-at-home orders. We had that for almost 3 weeks or so, where we were really wrapping our minds as a country around the COVID pandemic. And then individual states began the stay-at-home orders in response to that. And so we thought it was particularly important to look at how the actual orders of businesses to be closed and requirements for certain businesses just to not function at all, so people had to stay home. And like I said, while we found that domestic violence went up an initial 2-week spike. After that, it began to level out. So that's really what we found in that paper. The second paper, we looked at overall crime, violent crime, and property crime. And again, we saw variations where there were spikes in both. Property crime began to rise or lower a little more. And then we did was kind of base that around theory. So as you know, routine activities theory might really point out why people are staying home or not at businesses, why certain crimes might be occurring, why certain crimes might be lowering, is just because that's where victims and potential criminals come together in the same space and time. So if you lower that instance, then that would be that would explain that. So that's really the papers we found wrapped around those theories. The theory themselves kind of really explains what you might expect in crime. For instance, you would have fewer residential burglaries, but you might have more business burglaries. You would have fewer robberies, but you would expect things that like domestic violence to rise in certain places. So it's not surprising, some of the findings that we had in those two papers. I'll share those after this for the group to have those papers if they want to look at those. Just again, it's just Dallas data, and I was fascinated by the such variations across cities. That's I didn't even consider that. But moving on, I really kind of want to explain in a more experiential kind of way the things that I see, the things that I found that might change how police react. Again, as Dr. Richards pointed out, the change or the differences in calls for service are one thing, but when I analyze data, and I did this recently, not about COVID, but I pulled the arrests, the calls, and also the offenses reported, because they're not always the same. And this talk has given me a lot of ideas on where I want to take research now. It's just now I got to find the time, right? But on a personal level, I'll kind of explain just the average patrol, the effect that this has had on just patrol alone. But when you consider that what the country's going through, officers are also going through this on a personal level. We're fighting the disease, and we're riding in squad cars. And I don't know if anybody's ever sat in a squad car, but the dirtiest, most germ-filled thing in a squad car is the steering wheel, by far. That is the nastiest thing. So what our department was doing, and I believe probably other departments were as well, is they were widely dispensing the sanitizers, the sanitizer wipes. So you would have officers literally each time they go out to the squad car, wipe it down fully. I still do that. Everything from the keyboards to the mics to the key you use for the ignition key, door locks. I mean, you got to imagine everywhere you put your hand. So on what that really boils down to is every day when the officers are going to work, along with whatever stress, and we're probably all familiar with the literature on police mental health and stress, but on top of that, we have the what I would term the COVID effect. So they're hyper aware, not just what's going on outside of the squad car with people they've got to deal with eventually, but just getting started is a process, because you have to wipe anything down that anybody might have touched. So now you have these officers who are dealing with that, and we don't have. My favorite term that they coined over this was we're essential workers. So like doctors, you don't have a choice. You can't do a remote surgery. So that's the police officers have to go to work. We have to deal with people, and for many years we dealt with various diseases. I was here when HIV and AIDS come on the scene widely, late 80s, early 90s, and that was scary all by itself. And then we had the various different kinds of things, SARS or whatever, but even local things, not local things, but normal diseases you might think of, like tuberculosis. So we're already dealing with all of these folks when we come in contact with them. Then you figure our normal process of arrest, you're wrestling with these folks. Do they have any of these diseases you're already concerned about, especially the bloodborne diseases? But now we're talking about COVID, that somebody could simply sneeze on you at a house and you have it. And that doesn't, when an officer has COVID, we'll think about that for just a minute. When you have officers who also work part-time jobs or officers who work a lot of overtime, once you have COVID and you're out, you will get your regular paycheck if you have the sick time and can be out. But you lose, especially younger officers that count on the overtime on their paycheck or count on working part-time jobs. You lose that. You lose a big chunk of your income because you just can't be there. So they face that stressor on top of all the injuries they might receive anyway in a normal course of their duties. But then as COVID started kicking in, of course, you have the social distancing rules take place. The county, and I have the document there. I could actually kind of show you that, but the county issued a decree from the county jail that they were only going to accept certain prisoners, felonies and certain crimes, but minor crimes, minor possession of marijuana or minor out of town warrants. If somebody's wanted for a traffic ticket in another city and we find them, they weren't accepting those. So you have to really weigh on your police contact, especially your proactive policing. Are you going to stop as many people knowing that each car is a potential COVID infection? And if you do stop them and they have a minor offense, you can't arrest them anyway because the jail's not going to accept them. As it relates to domestic violence, you had people with mental health problems that we might take in a mental health warrant to a facility. Those were greatly limited because those facilities were either shutting down or they quickly at capacity because of the social distancing rules. So when you have officers who normally would handle a call in a certain way or handle an arrestee in a certain way, that suddenly is taken away. What that boils down to is officers who are used to doing their job a certain way now have to reinvent how they're going to work. Little changes such as not requiring people to sign citations. We would write COVID on the signature just to not make that extra contact with people. Did that limit officers from making traffic stops or writing tickets? Most certainly it did. And I haven't looked at the data. None of this, all of this is anecdotal. And that's why I wanted to present this. I wanted to give it a kind of a real officer on the street kind of point of view. When you have those effects, how does that then relate to later when researchers are pulling the numbers? Does that transfer into calls for service? Are people calling as much or not? We can't really impact that, but we can certainly impact the number of arrests we make, especially the more proactive stuff, which is a good bit of policing, our daily activity, but also crimes reported. If we're not contacting as many people or we're limiting the kind of calls we go to, then that is something that's going to impact your data later. So that would be, I guess, a suggestion for research to kind of consider when you see these differences in numbers across cities. What was the internal policies of the counties or the cities that affects that? And that's very important to understand because, officers are commonly referred to as the gatekeepers of the criminal justice system. That is where people enter the criminal justice system at the policing level. And if police aren't contacting people, they're not entering the system. Or if they're not making if they're not taking the offenses or making the offense reports because they're not contacting as many people, that would change that. We also have a system here in Dallas called a DOORS system. It's a Dallas online reporting system that began before COVID, but it was really re-emphasized to the citizens. This Dallas online reporting is a way of reporting various crimes online. You just go on and you make your own offense report online. You don't have to call the police. And, so that would affect your calls for service because they're not calling at all. They're just doing this report. And I don't know, but as you can see, the officer getting up and going to his or her job that day has changed so much. Then you are in some of the more violent areas we have more patrols. You do more crime, more violent crime, more readily, certainly more proactive stops. If you think about the end of the day, the data, because it's researchers coming in and pulling the data, and I pull the data and in my own research, but when you're pulling the data, you really got to think now, especially if you're going to talk about COVID or individual types of offense, violent crimes, domestic violence, whatever. When you start talking about that, those discussions, you've got to wonder, how did that number become a number there? What local policies affected that? What changes in officers' routines changed that? And is some of the numbers that we're losing from policing due to that? I mean, are people just, that's enough? For me, it was after 31 years, I've got to say, it's not even been a career. It's really just been a lot of fun for 31 years. I've enjoyed this job immensely and still do. But this was almost the last straw for me. It was just one more thing that I could go home, take to my family, and could literally kill one of my family members or my mother who lives close by that I go visit. Can I still go see her? And in fact, it's just a quick story that this happened. I've had a few friends die. We had hundreds of officers get COVID. But the one officer that died that I was friends with, he was perfectly healthy and then just died from people that he's come in contact with out on the street. And it's just, it's scary because that really sends home to you, okay, now I got to really be careful at work, but how careful can you be as a police officer, particularly in inner cities or more violent areas? I mean, you can only be so careful unless you just shut down. That does nobody any service. I mean, regardless of what's going on in society, you still need the police. Or police need to respond if you call them. So I just want to leave you with that. It's as you move forward in areas of research, whether it's medical, academic, when you think about how those numbers come to be, just give some consideration on those numbers got there because initially police officers went out and did something. I was very interested in hearing about the trauma related differences, and if you more stabbings or more shootings. I know now, and again, we don't even know the full effect of COVID yet, because we're starting to see now that people are finally getting out more and getting back to sort of what they were doing pre-COVID. We're in Dallas, we're starting to see a lot of big groups and a lot of shootings going on in big groups. We've had several large crowd shootings, multiple victims recently. I don't know if that's going on across cities, if it's just a sudden spike in that kind of issue, but it's not even summertime yet. And this will be the first summer that people really can get out. And I would expect that there's going to be a uptick across all agencies, whether you're experiencing lower crime, as Dallas has been fortunate. We're seeing a little lower crime than most cities, but I think any city is going to see an uptick simply because people are going to get back out. I think social skills have changed quite a bit just from this time when you're all caged up in your own house and can't get out. But I would really expect, as researchers start pulling this data from this summer, that you're going to see this post-COVID impact on both property and particularly violent crime. I would imagine it regresses back to the mean eventually, but I'll bet this summer you'll see an uptick. That's my prediction without any special statistics or regression modeling. I'll make that prediction. But anyway, as far as policing goes, just remember that local policies and internal policies have a huge impact on what officers do and how they respond to various calls. So I will leave it at that. I won't beat it to death, but I'll let it go there. And that's it.
Thank you to all of our panelists. I don't think that this group of people could have exemplified more of what it is that we try to accomplish with these lecture panels, which is trying to take an important issue and address it from multiple perspectives. And it raises so many questions. This is what our goal here today. I should say that the Department of Law and Justice Studies is sponsoring this. We wanted to look and understand COVID in a way that we don't typically think about it. And that's exactly what you did. You all raised a lot more questions here than we will have time to even begin to start to ponder. So first of all, I think it's most important that the folks that are joining us have an opportunity to ask questions. I have a million questions, but mine are not the most important. If you would like to ask a question, please feel free to put it into the chat box. You can raise your virtual hand and we'll be happy to get to you.
Kim,
So-
looks like we do at least have one question.
Please.
All right, so this is from someone named Geography Professor. So regarding crime and other associated violence during, oh, sorry, it's kind of cutting me off here. Let me see here. I just blow this up. There we go. All right, so regarding crime and other associated violence during the pandemic, trauma care remained stable with little increase and decrease. The domestic and intimate partner violence rate decreased, and in Dallas, domestic violence had an initial spike but then leveled off. Therefore, I believe that this discussion requires the revelation that the real cause of the increased violence is the defund the police movement, Black Lives Matter, and that liberal academics should not look for scapegoats among American conservatives. My first question is, why is liberal academia obfuscating the reality with the silly perception that COVID led to a greater criminal opportunities and an increase in violence? Well, that's an interesting question.
May I address some of that?
Sure.
Okay. So first, that's a good question. You have to remember that right at the height of COVID and the stay-at-home orders, we had the Floyd incident that led to just a great outcry against police tactics, and also re-upped the defund the police notion. And there's research that is emerging that is kind of looking at the COVID effect, but also accounting for the Floyd incident. And I think that's a good point, because that had such an impact in policing widely. Police officers, and again, I'm sticking strictly with the mental health side. You've got to imagine that the year or two before, police officers were widely regarded. In Dallas, in particular, following the 7/7 murders, if there's not familiar with what I'm talking about, July 7th, 2016, we had 4 Dallas officers and 1 Dallas area rapid transit officer murdered downtown during a Black Lives related demonstration that officers went out to protect the crowd, and ended up having five killed and I think 12 or 13 wounded. So there's no doubt that this resurgence in the initial outcry against police following the Floyd murder, that it had a tremendous impact on officers. Like you get the effect that you can do no right, but you still have to go deal with the calls. You're still dealing with the COVID incidents, so there's only so many people you can contact. It's really, those two things are really combined, and it's hard to separate those. A good time series does that a little bit, but like I said, that research is just emerging, and we're still dealing with that. So, is now the time to pull the evidence on that? Perhaps now, and then another year from now, to see if that impact has changed. But I don't. From the question, I'm not sure. I don't know that anybody is blaming COVID. What we're doing is looking at the spike, because we have seen in national numbers across the U.S. crime has changed. Some people, even when they're doing research, will drop 20 if they're looking at multiple years, will put a little asterisk by or drop 2020 data out because it's so different. In fact, in local data, I pulled some data on the crime around sexually oriented businesses over a couple of years, and the difference in 2020 was profound, because those clubs were closed largely during that time, so that crime would have dropped off. So researchers, academics may be dropping that out because it's such an effect. So there is a real effect. What that's from, we can certainly say that COVID had an impact on that, but we can't unmarry, or we can't divorce the defund the police or anti-police sentiment out of that, because it occurred right at the height of that. So that's a good question for researchers to really think about, because at the end of the day, if you have officers who are already thinking about leaving, or they end their career a little sooner because of COVID, but maybe they decide to stick it out a little bit, and then you have this movement where they're just vilified and families are threatened, or you're afraid if your wife goes to work, is somebody going to follow her, or kids are harassed in school, which is not uncommon now, unfortunately, police officers, children in school. But do you say, oh, that's it, I'm done, that is the final last straw, I'm out? And we've had many retire. We still, in my own city, we have people retiring in droves, and I don't know what the reason is. No, I don't ask them that, but the question is good. So COVID didn't lead to a greater criminal opportunity. It changed the opportunities, which, if you study theory explains that. Routine activities has, in my mind, become even more relevant now, because it really highlights the differences in how people move around and where crime occurs and what types of crimes increase or decrease. I hope that answers the question as best I can. But anyway, that was my shot at that question.
I guess I can say one thing, if I may. When I was listening to some of these, I think there is sort of a sentiment to perhaps want to vilify each other when we're under stress and things like that. But when I hear, Dr. Bishop talking about some of the experiences that they had on the police side, I can resonate with that 100%. Physicians and nurses were going through a similar thing. So I think when you come down to it, sort of anecdotally, we're all sort of we're trying to get through this to the best of our abilities, and we pull these data to try to understand what is happening and how we can help each other. But I think when you get to it anecdotally and you're talking to somebody else, we're going through very similar experiences sort of nationwide. And there were a ton of physicians who did not see their families for months, who were staying in hotels or who were doing other things because of the same things. We didn't have personal protective equipment, for example. We had shortages of physicians. We were doing we saw that trauma care was sort of unchanged. We were doing not only just trauma care, but we're taking care of COVID patients, and we're taking care of stroke patients, and so I think when you think about it, at the gist of it, we were all, COVID was a very stressful time. It stressed our resources. It stressed us, emotionally, physically, I think all of us, right? So I think, although there's this sentiment to want to vilify each other, I think many of us were going through very similar experiences, so I just wanted to say that out there. Not any data, but my perception.
No, you're absolutely right. And that's what I wanted to point out is that it's you and I and people in similar fields have, our jobs necessitate us contacting people that we wouldn't normally come in contact with if we had the choice. You don't have that choice. That's the career you've decided to do. And that's certainly stressful, because it's not just you get to do work and then go home and forget about it. You take the mental stress home, but in this case, even the COVID virus you could take with you. You don't get to leave it at the hospital, and that certainly is on our minds, as well as I know it's on yours as well. Plus, I know doctors were you didn't just get to quit doing everything else and only do COVID. That was just an added stress. So yeah, that's a point well taken. Thank you.
Can I just ask a couple quick questions? Egodage, if you talked about seeing a decrease, then back to baseline, and then you actually saw an increase in terms of brain trauma and battery, that you see as a surgeon. Were there any changes in relation to that?
We do notice that for certain types of trauma, for firearm-related things, for example, and penetrating trauma, those may be affected by people's economic, and socioeconomic status, and which is why we have tried to obtain funding to specifically help particular populations that we find to be vulnerable. And again, we have a lot of community workers in Camden that help with that. But your point is valid, that it is very difficult to sort of unmarry those things.
It is.
But yeah.
Dr. Richards, one of the things that was very interesting, you talked about the idea of third-party callers. And I think about routine activities theory. Do you think that, you're smiling, yeah, I know, right? We immediately go to this idea. Do you think that the increase in outsiders calling in about potential domestic violence or intimate partner violence may be an increase in guardianship because more people are at home, more people are being attentive to their neighbors, they're not at work, and they're actually seeing more about it, what is potentially going on? Is this potentially routine activities theory that we're seeing, do you think?
So this is so hard to disentangle because
I know.
And I say, so this specific point is really hard to disentangle because I wonder about almost a replacement effect, because you had all these kids that were no longer in school, and teachers and school psychologists and school social workers, and pediatricians doing, and primary care physicians doing regular, routine visits. That really stopped, during, the height when people were staying home. They are huge. They're a huge portion of disclosures, right, of domestic violence, child abuse and neglect, right, and referrals to child protective services. So I just don't know. I mean, the answer to that question is I just don't know. I think it's in terms of direct calls to the police, it makes sense, right? It makes sense. Yeah. But like Stephen said, which is, it's so important. These call for service data, they're very tricky. We replicated the same methodology as others that were doing this work in terms of like the keywords we were pulling out, how we were coding these calls for service, but it's not super clean. Like, oh, I checked this box and these are all the domestic violence calls and these are all the intimate partner violence calls. Like, that's not how calls for service necessarily come in. So you don't know, is it a victim? Is it is it a neighbor? Is it a teacher who's making that third party report at school? Like, there's no way to distinguish that. So some of these questions are really difficult to answer with the type of data that we have access to. And as Dr. Bishop said, just because a call comes in as suspected domestic violence doesn't mean it necessarily ends up being that. And a call could come in as something else and end up being domestic violence, right? Yeah. So we basically did the best we could. We used the same methodology as others so that studies could be comparable to each other, but that doesn't necessarily mean that that the data is perfect, right? And we know, the data is never perfect, but this especially, it's really hard to disentangle some of these, some of these details with the data we have.
Oh, hands down. It will be interesting, as data is always, right, we're always limited in what we can assess and draw conclusions about. because
Which
our
is
data-
why it would have been so great if we had triangulated the 3 types of data we used and they all said the same thing. That was that to us, that was the real pickle, because when the NCVS supplement came out and DV, the rate of, reported victimization went down. I mean, I was just like, what?
Yeah.
So, I mean, it really is. It's very difficult to disentangle all of these impacts.
Yeah, as Carla said, it's sometimes, we're so surprised by the things that we see are so counter to what we anticipate seeing. And clearly, I wish beyond, I can't even tell you how much I wish. I have 3 pages of questions. And obviously, I don't have the opportunity to ask any more because we did promise everybody that they would only be kept till 12:30 and we kept you over. I hope perhaps we have some student questions. If the 3 of you wouldn't mind, perhaps we can send you some questions and at your leisure, perhaps be able to answer. But we really genuinely appreciate this. Has been so interesting, and you've not only answered a lot of questions, I think as good academics, you've raised more questions even. And what Dr. Bishop is saying is like, okay, now I got to find the time to try to figure out how I can maybe do some research and answer all of these. But it's been very powerful to hear all of you speak. It's been really very, very interesting, and we cannot thank you enough. Carla?
No, I think you said it really well. We appreciate you coming, and I personally learned a lot as well. So thank you so much. And I hope that everyone knows that we will have the recording up. I'll find a way to disperse it, probably on social media, but it will be there. So thank you, everyone, for coming.
And thank you to all our participants. Yes, we are the people that attended. I know I know there are people that wish they could have come that could not because of timing, but Carla will get this up and be available. Thank you so much for sharing your really precious time with us.
Thank you.
Take care.
Thank you for having us.
Thank you.